We now have two brief but important keynote presentations by Yun-Hee Jeon and then by Jacqueline Troy. So we're going to go to Yun-Hee Jeon first in terms of her presentation. Yun-Hee is a registered nurse, academic and leading Australian researcher in psychogeriatrics and gerontology. Her research focuses on developing innovative and creative approaches to improving the health of older people with dementia, depression and other chronic illnesses. And she does something which I think is really important, which is studying care, quality and service delivery for these very vulnerable populations, how we increase workforce capacity, how we establish evidence-based practice and tools for assessment and outcome measurement in dementia. You know, we spend a lot of time discussing actually discovery. We don't spend enough time actually discussing practice and how evidence-based practice actually is, and the key role played by all health professionals acting collectively in this important area. And for those of you who've ever tried to deal with either the mental health system or the aged care system, you'd be well aware of the challenges in real life practice that exists. So great to have this presentation now from Yun-Hee. Welcome to this afternoon's symposium, Yun-Hee.
Okay, good afternoon. I hope people can see me and see my slide. Thank you, Ian, for the introduction. It's my great pleasure to be able to speak at this Brain and Mind Symposium this year with the key theme of researchers leading the brain and mind sciences through the translational pathway from the lab to the living room and beyond into healthier communities and policy. What a great theme. Before I begin my talk, I too like to start by acknowledging the traditional custodians about the land, the Gadigal people of the Eora Nation, where I'm speaking today, and pay my respects to their elders past, present, and emerging. I extend that respect to Aboriginal and Torres Strait Islander people here today. In the next 15 minutes, I'll provide you with key points on why we care about rehabilitation, what evidence we have around dementia rehabilitation, including some of the work that I have done with local and international collaborators on dementia rehabilitation, and try to answer the question of my title today, are we ready for dementia rehabilitation in routine practice? And conclude with some of the things that we can and we need to do. I start with Lancet paper that was recently published. This is the first study to produce a global estimate of the need for rehabilitation services. And using data from the Global Burden of Disease, Injuries and Risk Factors study, the authors in this paper estimated the need for rehabilitation by presenting the prevalence and years of life lived with the disability of 25 diseases that would be amenable to rehabilitation at some point in the course of the disease. And dementia is one of the 25 conditions they included. As many of you know, approximately 55 million people live with dementia around the world. And I don't need to tell you how many people can benefit from rehabilitation when they say that 1 in 3 people or with any of those conditions could benefit from rehabilitation. And that means 310 million years have been lived with the disability of those people we could support. Now, let me briefly talk about rehabilitation. People seem to understand rehabilitation when someone has a stroke or have accident, physical issues. But when it comes to dementia, we somehow have lost the definition or the meaning of rehabilitation in translation. Rehabilitation is a set of interventions needed when a person is experiencing or is likely to experience limitations in everyday functioning. And that that includes aging or health condition, including chronic diseases and disorders, injuries and traumas. So the definition is very broad. We hear about different terminologies that, reablement, wellness approach, or sometimes the function-focused care, depending on the settings where rehabilitation is offered and the form of rehabilitation. But when it comes to rehabilitation, what is consistent is about, it focuses on person-centeredness and the person's functional independence, not necessarily the treatment of the disease, but it is done through the measure of preventing and slowing down their loss of function or its further decline. And it can be delivered in different shapes and forms and settings, and often under different names. And that's why we tend to have those different terminologies. And it includes a single therapy intervention. It could be exercise, cognitive stimulation, reminiscence therapy, speech therapy, or it could be in multidisciplinary or specialist-led programs or multimodal rehabilitation programs. So I'm going to, introduce some of those things that we've been working on. But I want to highlight, when we think of rehabilitation, that the definition, the meaning of rehabilitation clearly aligns with this renewed definition of health I quite like to use. And health is a dynamic balance between opportunities and limitations. So it's not just a static position that we're talking about. It is actually process, and it really needs to focus on the individual's ability to adapt and to self-manage. And so when we provide rehabilitation, we need to consider the individual's capacity to fulfill potential and obligations and their ability to manage their life with some degree of independence, despite their medical condition, and their ability to participate in social activities, including work. But whenever we talk about dementia rehabilitation, we seem to be rather puzzled about whether that is relevant or not. It is getting better, but this was the speech, a part of the speech Kate Swaffer made in 2015 at the World Health Organization's Ministerial Conference on Global Action Against Dementia. And this is her story. And she said, when I was diagnosed with dementia at the age of 49, I was told to get my end-of-life affairs in order, to give up work, to get acquainted with aged care, and to go home for the time I had left. And she termed this prescribed disengagement. And the interesting part is that she said, if I had been treated after a stroke, there are ethical and rehabilitative national and international guidelines. And 5 years on, 6 years on, we still hear about these, stories similar to what Kate experienced. Now, when we therefore conducted a systematic review of what kind of, dementia rehabilitation interventions are available, we was rather surprised that there were lots of them, but we don't seem to actually use those interventions in our routine practice. So I was invited to lead a technical working group by WHO to look at the best, dementia guidelines, to tease out what kind of interventions have been included in those guidelines. We reviewed, 25 different guidelines and chose 6 best guidelines and identified 330 recommendations. And about 15% of the recommendations have very strong recommendations with high-level evidence. A lot of the recommendations presented were based on expert. So the review clearly presented us with opportunities to do more rigorous research in this area. But it also gave us some hope that there is a range of interventions that clinicians can actually offer in their daily practice. That includes group cognitive stimulation therapy, group reminiscence therapy, and so on. So, it was a really great opportunity for us to be able to see those interventions recommended in those guidelines that included the UK's NICE guideline and Australia's clinical practice guidelines for dementia. We also did some work around, these are the single interventions, but what kind of programs that has a multimodality to address dementia rehabilitation. So we reviewed the 28, dementia rehabilitation programs, and these are the programs that were offered in the home environment, institutional environment, such as aged care homes or hospital settings, or clinic or center-based, programs. And it was really, great to see that most of the programs that we reviewed reported a significant post-intervention improvement in the individual's functional independence. We also learned that a lot of programs targeted mild to moderate stages of dementia, and most of the programs are offered at home. But what we also found was a lot of programs, the dose and durations quite vary. It could be, 4 hours to 234 hours. And of course, depending on what each of the program wished to achieve, that they would have different components in their modality. But when we looked at this, a range of different programs, it really helped us to see where, there is enough evidence around. But then at the same time, why aren't we doing anything about those things? So, when we did a review, we also at the same time tried to look at what kind of things that can be actually offered in the real setting. So one of them is actually the most well-known rehabilitation intervention is cognitive rehabilitation. And this is the latest study led by Professor Linda Clare from Exeter University. And they demonstrated their cognitive rehabilitation program really supported individuals' goal attainment, and their target population groups were people in the early stage Alzheimer's disease and vascular or mixed dementia. So, what we are seeing now is that there are programs that are targeting a particular type of dementia or types of dementia, or there are programs that are offered for dementia without any specific health conditions. But one of the programs that we have done in Australia is that COPE study. This was led by Professor Lindy Clemson. And it's, this is a reablement program, and that there was the focus of this particular trial was an implementation trial. COPE program was originally developed by Professor Laura Gitlin from Johns Hopkins when she was there, and it was quite successfully demonstrating, COPE program improving individuals' function. So the COPE program was also, we wanted to figure out how they can be successfully implemented in Australia. And the program, the outcomes clearly demonstrated that is feasible, it can be delivered, and it actually improves carers' well-being and coping, and also activity engagement of the person living with dementia. The latest program that we are trialing is the IHA program. This is the program that has a unique aspect of a registered nurse and occupational therapist and other allied health professionals working together as an interdisciplinary team. And this is an international collaboration with Johns Hopkins and the Bangor University. And we are funded by the NHMIC to conduct this study between 2018 and 2022. And so it's about, going one step further to really figure out how a reablement program can work in the existing healthcare system. So we have chosen hospital settings and aged care settings. So we are working with Concord Hospital, Canterbury, Royal North Shore, Wright Hospitals, and 2 aged care providers, Anglican and Baptist Care. So we have 130 DIAs enrolled in our study, and we are in the final stage of our trial. So the program itself is offered over 4 months period, and it is very much designed to support individuals' function. We are hoping to be able to demonstrate the cost effectiveness of this trial, because when we did our earlier pilot study, we were able to demonstrate our IHAB improved quality of life for people with dementia, and also it improved initially the person's functional independence. So we were very encouraged by this pilot study, and we also had a great success from in terms of feedback from our carers. And the person you see here is the person, who participated in our pilot study in 2016 and 17. And she this year she had a 93rd birthday. So we are very pleased to see, she's still staying at home, because one of the things that we really want to demonstrate is that, by offering rehabilitation program, people can stay home as long as possible and as well as possible. So my answer to this question, are we ready for dementia rehabilitation in routine practice? I can say we are nearly there, not quite there, but there are a lot of places or services that offer this type of program. But what we need to do is that we need to do both the top-down and bottom-up process. We need to, start the model of care by co-designing and implementing this program, working closely with partners, industry partners, and the consumers, and also policymakers. And the key is interdisciplinary teamwork. Each individual can offer their own skills to offer the rehabilitation interventions. But when it's a really interdisciplinary teamwork, we can achieve a lot more. We need to train more workforce with the skill sets, to offer the rehabilitation program. We need to be able to, offer this program that is easily accessible. What we also found was the reframing of dementia narratives is really important. So it's not just clinicians knowing about rehabilitation, but it's also people living with dementia and the carers being able to accept that there is something that can be done to improve their everyday function. So these are the things that we would really like to see happening, and model of care is something that I would strongly encourage that we work on. So I want to just close my talk by saying that we recently launched the Forward with Dementia, and this is a website that people can go to, and there is quite a lot of information that support people to be able to learn about how they can live well with dementia after the diagnosis. Thank you.